Hello, I'm Dr. Melissa Walton-Shirley for theheart.org, and we're coming to you today from the Paley Center in New York, where we've gathered for a very special media event entitled In the Prime of Her Life. This Mayo Clinic sponsored program is both a focus and an update on women and cardiovascular disease. We have with us today two distinguished members of the cardiovascular community, Dr. Nikayla Cook of the NHLBI and Dr. Walton-Shirley of the Mayo Clinic in Rochester. Welcome, both of you.
Thank you.
Thank you.
Our discussion today will focus on what ails the young woman's heart. We'll be looking at issues specific to premenopausal women. Dr. Cook, I wanted to start with you. I thought the commentary you made was very fascinating about healthcare deliveries and disparities, how there are certainly differences between the genders and ethnicities. Why are the death rates higher in females, especially for heart disease, African American and Hispanic population? Why is that?
I think that that's likely a multifactorial problem that has multiple contributions from different areas. I think some of it may be related to a patient-specific issue or a provider-specific issue or healthcare system-specific issues or the combination of many of these things. Particularly, we know that from the patient perspective, what they come to the office with, their background, their cultural preferences, as well as their income, insurance status, and many other issues such as housing and education play a role in their health care as well as their outcomes from health care. We know that from providers that there are other issues that enter the interaction that we actually may have control over, such as unbiased stereotyping, as well as, unconscious stereotyping or unconscious biases that we may need to address in order to really understand why there are differences in outcomes and differences in the quality of care. And from the healthcare system perspective, I think there are several issues that contribute to these differences in care and outcome, some of them being related to insurance status, some of them being related to navigation of a very complicated system. So I think the answer to your question is that really this is a very complex issue in terms of why there are differences in death rates and why there are differences in the way that healthcare is delivered, because I think it has many contributors from many different areas of the healthcare arena.
You know, you made a very excellent point about the patient-provider relationship. So what if I'm a 40-year-old female and my father had a heart attack at age 55? What types of things do I need to ask my health care provider to do for me in order to screen me or to maybe implement some prevention?
I think it's really important that women understand what their risk factors are, including their family history of risk for heart disease. And in that patient-provider interaction, I think it's important that women feel empowered, that they can ask the questions such as that, meaning that I come from a family where this is a situation, what does that mean for me? And have that meaningful conversation with the provider to understand the personal risk. Women should know that they want to ask, what do I need to do now before I have any symptoms or risk factors so that I'm prepared to try to prevent this from occurring for me, as well as if my father had disease at 55, when do I need to approach thinking about screening for heart disease, and what does that entail? Women need to understand that knowing their own numbers, their blood pressure, their cholesterol, their weight, are all factors that they can control and that they should start addressing at younger ages than the age in which heart disease developed in their family.
So is it important for a premenopausal female to know her cholesterol number and to implement therapy, pharmacologic therapy, or is it more a dietary exercise approach that might be important for the premenopausal female?
I think for the premenopausal female, it's very important that they know their numbers in order to start a personal action plan. But of course, if by guidelines it's recommended that pharmacologic therapy is necessary, then it's important to implement. But I think that the primary issue is making sure that they know what their risk is, understand their personal risk, take it seriously, and then try to engage their physician in what can I try to accomplish from a lifestyle perspective, what do I need to accomplish from a pharmacologic perspective, and how do I partner with my physician in order to make sure I'm meeting the targets and the goals.
Important to have a practitioner that you feel comfortable with and you can approach.
Absolutely.
Dr. Shirley, I know that your specialty is mitral valve disease and repair, and it's a significant issue for women around the country. I think for those of us who see patients on a daily basis, we struggle with understanding the timing of mitral valve repair. I don't know whether or not to follow the LV function or the patient symptomatology, et cetera. So can you please address the timing of mitral valve repair issue, please?
Well, that's a good question, and as I mentioned earlier, there's really multidisciplinary teams around the country, including at Mayo Clinic, studying these exact topics. The short answer is that once a woman presents with severe mitral regurgitation or even moderate to severe mitral regurgitation, that should be taken very seriously. At that point, we need to assess a number of factors, including echocardiographic parameters such as the size of the left heart chambers, both the ventricle and the atrium, as well as other factors such as the existence of atrial fibrillation, pulmonary hypertension, and certainly symptoms. Now, once a patient develops symptoms, then we know that it's actually too late. We know that the prognosis associated with that condition is poor, even following surgical correction. So the suggestion would be as follows. Once a patient presents with severe mitral regurgitation or moderate to severe mitral regurgitation, a thorough transthoracic echocardiogram should be performed. And that should be reviewed with a cardiologist and a cardiac surgeon to decide on optimal timing. It's not a decision that can be made routinely in the community in the absence of specialized echocardiographic support.
Will you address again the two factors you stated that cause most women to put surgery off? What's special about a woman's inability to make that decision to take that large step?
Well, that's a good question, and we have to understand the barriers to healthcare delivery and the assumption of healthcare once it's offered. So the ability to avail oneself of the benefits being presented. And in the case of young women, they're in the midst of their careers, they're in the midst of raising families with responsibilities, and the AHA survey, the online survey, identified two key factors that are barriers to women availing themselves of the benefits of heart care in their lives. The first is the fact that they're caregivers. They're caregivers for their families and friends. And number two is family-based responsibilities. So what's important to help women understand in the clinic is that this is a life-threatening condition and effective surgical therapy exists. So if women aren't given the opportunity to pursue such therapy, then really they're not able to be there in an effective role in the future for their patients, for their family members and those that rely upon them. So it's really important that we help people understand, and particularly young women who are in the midst of their productive years, that seeking life-saving therapy is very important to normalize their survival and get them back to that normal life expectancy that we would expect from an age and sex matched population.
So why is it the best time in medical history for a woman to undergo a mitral valve repair?
Well, it's an important point. Mitral valve repair techniques have been honed over the last 40, 50 years at Mayo Clinic and other places around the world. In particular, we've had gold standard results utilizing techniques which really are as effective for posterior leaflet, anterior leaflet, and bileaflet prolapse. What's new in the last couple of years is we've been able to duplicate those techniques almost exactly, in fact exactly, utilizing minimally invasive techniques. So in other words, we're able to perform a full mitral valve repair, including annuloplasty band or ring, through a closed chest approach, employing port access incisions between the ribs of a woman in the right chest. And this not only provides a smaller, less noticeable surgical scar, but allows patients to be extubated in the operating room or having the breathing tube removed, transition to the floor the same night, have less blood transfusions, be dismissed from hospital 3 days after surgery, and return to their lives, their family, and their work more expediently.
That's great. Dr. Cook, can you talk a little bit about what our global approach should be, even maybe on a statewide level and a national level, to try to improve access for women to cardiovascular health care? Are there things that we can do as practicing physicians that can help to advocate for our patients more effectively?
I think that this is a message that really patients and providers have to take to heart, that basically we understand that there are differences in access to cardiovascular procedures, to cardiovascular quality of care, and even to referral for specialists amongst women and of individuals of color that have reduced access. And so what we really want to do is take the message out and say, here, we know this to be the case. Now let's try to get together and try to think about solutions to decrease this problem in our area. We've learned that certain referral type based situations where there may not be easy access on a regular basis can actually improve access for individuals who are coming from certain practices or certain communities. And so perhaps thinking about that strategically in terms of how you get women into practices that wouldn't have normally been there is something that communities can do. But women can also advocate. Women can advocate and be empowered to advocate for the appropriate interface between a generalist and a specialist, to know when it's time for them to go on to see a specialist and to ask for those referrals in their provider interactions. So I think it really is a two-pronged approach for both the patients and the providers to get engaged in how we actually address the issues of access in our communities.
Sure, and Dr. Suri, I wanted to speak with you about pregnant females and heart surgery. You know, a lot of us really would prefer not to ever have to deal with that issue, but more and more we're having to do that. So can you talk about some specific considerations in the pregnant female that's facing maybe a mitral valve repair?
Yeah, that's a good question. The most important thing to remember is that the health of the mother it affects the health of the baby. So, in other words, if we're unable to ensure the health of the mother, then we're really not doing anybody any benefits. That said, once it's clear that a patient has cardiac disease, they should really be referred on to a tertiary or quaternary center that specializes in maternal fetal medicine and high-risk deliveries. If a patient requires surgery for severe aortic valve regurgitation or severe mitral valve regurgitation, the recommendation would generally be to proceed with that surgery. Of course, that will need to be decided in conjunction with the high-risk obstetrician and gynecologist, and it really needs to be handled on a case-by-case basis. But these questions shouldn't be handled alone. There are experts out there, and really the message would be is that the patients and cardiologists should really seek the expertise necessary to get that patient to the best hands possible.
When you mentioned gynecology, it made me think of a comment that you made, Dr. Cook, about how we need to interface the primary care physician with the gynecologist, with the cardiologist. So how can we do that? How can we have these conversations with our fellow physicians who are actually in another subspecialty to try to make them more aware that we need to do more intensive screening for our patients for cardiovascular disease?
I think that's a really important question and something that may be different in different communities or provider organizations than others, but I think it starts with natural conversations. And I think a lot of the conversations that we talk about amongst ourselves are really patient-driven. And so if we have a patient that's presenting to us, we need to think outside of the box in terms of how we're going to manage things, because often the relationship for young women is with their primary care physician or their OBGYN. And so engaging the OBGYN and the primary care physician in this activity is a very important, I think, goal for this panel today and probably the awareness raising we're trying to do here. Specifically, we at the National Heart, Lung, and Blood Institute do put together opportunities for physicians to learn about heart disease and prevention, and we do focus on generalists and primary care physicians as well as OBGYNs, and so we recognize that there really is a role for these individuals to play, but we need to make sure that the interface between the generalist and the specialist is there when it's appropriate to be there.
Absolutely.
You know, on that point, we have to acknowledge that the rate of doubling of medical knowledge is really phenomenal. I mean, it's hard for any of us to keep up with the latest developments. For example, even our own institution, some of the cardiologists in our practice aren't aware of some of the novel procedures we're able to offer, including hybrid procedures. So a good message for people to take away, whether it be patients, primary care physicians, or cardiologists, is that there's no shame in getting help from a multidisciplinary team and referring patients on to centers of excellence. So for instance, with the issues that my colleague is speaking about, or perhaps high-risk mitral valve repair surgery, or even complex mitral valve repair surgery, those patients should really be referred to centers of excellence in certain instances to ensure that they obtain the optimal care.
I agree. I think sometimes the most important aspect of your day is to know what you don't know, or know when you do need help to help another individual. Dr. Cook, what's the take-home message today from the In the Prime of Her Life forum? I thought it was a really excellent program, but is there some salient point you'd like to get across today that sort of winds it all up for us?
I think the major point I'd like to get across is that we know that Americans overall have had improvements in their heart health over the past few decades, but we haven't all equally shared in those improvements. And so we really need to recognize that there are differences in both the utilization rates of procedures, the quality of care received, and the outcomes in cardiovascular care for women and people of color, and that we all have to play a role in trying to make sure that we're aware of these problems, doing everything we can in our everyday activities in order to address them.
Absolutely. Dr. Suri?
Well, some of my comments were echoed in the last statement I made, but I would echo that to say that women with heart disease, structural heart disease, have a condition that's no fault of their own. These are conditions that are degenerative. They happen regardless of the risk factor modification that is important in certain other conditions. And once a critical structural heart disease problem is found, a referral to a center of excellence, a multidisciplinary team to determine when and what type of surgery is available and necessary and appropriate is key. So let's not assume that we know what's out there until we seek the expertise of those on the cutting edge, and let's get our patients the best care possible with the least functional burden on them. In other words, let's get them back to their lives as quickly as possible and let them be the productive members of society and the caregivers and the active members of their family that they all want to be.
I know. I think it's comforting that the help is there. We just need to network for the good of our patient and to advocate for the good of our patients. And I thank you for helping us to do that today. It was a pleasure to have both of you on our program.
Thank you.
Thank you very much for joining us here on theheart.org.